In honor of Mental Health Awareness Month, it's my pleasure to welcome everyone to our webinar series, At the Forefront of Mental Health. I'm Maureen O'Connor, president of Palo Alto University. At Palo Alto University, we are dedicated to addressing pressing and emerging issues through research and training in the fields of psychology and counseling. Today's discussion focuses on the changes taking place nationwide among police departments in the way officers respond to mental health calls. The panel will also address the increased attention being paid to officer wellness. Moderating today's conversation is Dr. Patricia Zaff, Palo Alto University's Vice President for Continuing and Professional Studies. Dr. Zaff is a highly regarded forensic clinical psychologist, and prior to joining PAU, she was professor of psychology at John Jay College of Criminal Justice, the City University of New York. She's a fellow of the American Psychological Association and a distinguished member of the American Psychology Law Society. Dr. Zaff, we're delighted to have you lead this important discussion today, and I'll turn it over to you.
Thank you, President O'Connor. Welcome, everyone, and thank you for joining us for what promises to be a very insightful and meaningful discussion. Today's topic is an important one, and we have an esteemed panel to discuss and highlight some of the key issues that we grapple with regarding policing and mental health. This panel is part of the At the Forefront of Mental Health series, which has a focus on highlighting key areas of practice for current and aspiring mental health professionals. So law enforcement regularly responds to service calls for individuals with mental illness who may be in crisis. Officers and deputies need the knowledge and resources to effectively respond to these crises, while also ensuring the safety of the individuals with mental illness, other community members on the scenes, and themselves. Just like law enforcement officers address mental health issues in the community, agency leaders must address the psychological and emotional well-being of their officers. Mental health and resilience are core elements of officer safety and wellness. Therefore, officers must be able to not only withstand the day-to-day work-related stressors, but must also be able to recover emotionally from traumatic events. Today, we attempt to discuss the complex issues involved in policing and mental health from various perspectives, and I'm pleased to introduce our esteemed panel. Chief Robert Johnson has been in law enforcement since 1986 and has served as Chief of Police for Palo Alto Police Department since 2018. Dr. Ellen Kirschman has been police psychologist for 40 years. She's a member of the International Association of Chiefs of Police, the American Psychological Association, and volunteers for clinical services at the First Responder Support Network. She is the author of I Love a Cop, What Police Families Need to Know. Dr. Mark Kamina is a licensed psychologist and board-certified specialist in police and public safety psychology, chair of the First Responder Psychology Certificate Program at the Wright Institute, co-founder and director of research for the First Responder Support Network, residential treatment programs for first responders and their significant others. Ms. Angelica Hendricks is a registered associate marriage and family therapist at Integrated Psychological Assessment Services. She's a trauma-informed clinician who has experience working with first responders and adults dealing with PTSD, depression, anxiety, relationship difficulties, and communication challenges. Ms. Catherine Parlett has worked for the County of Santa Clara for over 20 years. Her experience includes 10 years of inpatient psychiatric work at Valley Medical Center, Foothill College, the Washington State Penitentiary, and the Gronowski Clinic. Dr. Michelle Hoy-Watkins has more than 20 years providing police and public safety psychological services. As a police psychologist, her work has included conducting pre-employment psychological screenings, fitness for duty evaluations, campus and workplace violence risk and threat assessment, and relevant trainings for various law enforcement agencies. I'd like to start with some discussion of what each of you see as some of the biggest challenges we face when it comes to mental health and policing and mental health. Chief Johnson, I'd like to start with your perspective on challenges.
I appreciate being with all of you today. Yeah, I am Bob Johnson. I've been doing this for 36 years, being in law enforcement. But as we reimagine policing, especially the conversations we've had over the last couple of years, I'm really excited because we have been able to implement the psychiatric emergency response team here in Palo Alto. And this is in partnership with the Santa Clara County Department of Behavioral Health, and we were the first municipality and the second agency in the county to actually offer an alternative service delivery model. And really what it's about is it's a program that partners up police officers with licensed mental health clinicians to provide that rapid intervention to a person in a mental health crisis or experiencing a crisis. And PERT, as we call it, allows us to bring that mental health resources with us to the calls for service, providing that mental health expertise that's so needed when and where it's needed. I think the challenges right now is just access to services and really having officers equipped with knowing all the services that are available, especially as they serve our communities. And I think that goes to the advantage of having these psychiatric emergency response teams, because the mental health clinician is usually going to be connected to a lot of those services. And having that in the car with the officers as they respond, extremely beneficial. And like I mentioned, we've had this team in place going on, 6 months, and they've responded to over 175 incidents and been able to provide care to 150 individuals. And probably most impressively, there's been no force used in any of those incidents. So they're able to de-escalate the situations, get the individual the resources they need or the services they need, again, when they need it. And normal patrol officers, just because of the capacity, they don't have the time usually to dedicate that much time to a specific call to make sure it's handled the way it needs to be handled. And that's why I love this particular model. And I think, honestly, I think it's a model that really needs to start expanding dramatically throughout the profession.
Can you tell us just a little bit more about the model?
Yeah, so this has actually been a model that we've been in the works for many years. It was well even before I came in here. The conversation started due to an incident here in Palo Alto involving the response to somebody who was having a mental health crisis. So the conversation really began in about 2015, 2016, but it was the challenge of hiring the clinician on the county side to partner with the police officers. So when I got here in 2018, we had already committed to it and we made it a priority to make it happen, but it took 4 years to get that clinician hired and into the car with the officer. So again, it goes back to that access, the challenge of hiring, recruiting. So I really think this is going to be a huge demand. And I think that's what we need to do. Right now, we have one team in place for the city of Palo Alto. We would love to have two. And the reason I say that, we would at least like to have 7 days a week coverage. Because with the one team, we're only allowed to provide 4-day coverage at this particular moment. And in the meantime, we also have overlays with the county. They have their trust program, which is a 100% non-law enforcement response that can respond to non-crisis situations. So the team works with that, collaborate, that component. So we have a nice layering effect between patrol, PERT, and the trust program.
Thank you for that. From Chief Johnson's perspective, finding those clinicians to work with police officers isn't necessarily an easy thing. Dr. Kamina, could you talk to us a little bit more about what you sort of perceive as a lack of culturally competent clinicians and what we might be able to do to produce more clinicians?
Yeah, certainly. So it's really important for us to have trained, culturally competent clinicians who can handle this. And one of the ways we do that is through the Right Institute program that we developed to cover 55 different proficiencies in police and public safety psychology. And it covers 4 domains: assessment, operations, consultation, and intervention. We also train people at the First Responder Support Network. Initially, we have volunteers who help out at the retreats as peers. And it's an important element of our treatment that we believe that it's a mind, body, spirit program. So we have peers, we have clinicians, and we have a chaplain present throughout the 6-day program. And one of the things that we do is we have these residents come through the program, but then they return to be able to pass it forward. This brings up another issue. I think we were talking about the problem associated with addressing mentally ill folks on the street. And many of us know that several departments use the Memphis model, which was developed by the Memphis Police Department, to train officers on how to de-escalate their work with the citizens, and to be able to basically talk them down. And so they approach the citizen in a non-confrontational manner and just speak to them as they're speaking like a friend. And I think that's the most effective way in being able to deal with these situations.
Thank you for that. Dr. Hoy Watkins, you want to tell us about de-escalation training?
Sure. And I also wanted to comment on the importance of the education and training in terms of exposing students. And so one of the things that I'm really excited about in terms of an initiative as the chair of the Police and Public Safety section of Division 18 is that I'm going to be working with some historically Black colleges and universities to expose their undergraduate psychology students to the field of police psychology. So in terms of sort of raising awareness around just our field in general of police psychology, but also trying to promote and raise culturally competent psychology students who will be the future of the work that we do. It's an initiative that I think is really important. And as a graduate of Xavier University in New Orleans, I'm starting with that university first. So I wanted to just share that exciting news. In terms of de-escalation, some of the techniques that I try to promote, and I think we've already heard some of this, is trying to just engage them in understanding the importance of effective communication. I think it was already said, but the importance of making sure that we maintain respect and not speaking in a condescending or humiliating way. People are always watching. We are living in a culture where everything is recorded. So to make sure that our interactions are respectful. I also, when I train officers, I explain to them that it's important to engage in other sort of effective ways of communication in terms of using I statements. This allows the individual to understand that the officer is listening. It conveys that they are actually listening. Also using open-ended question allows the officer to sort of gather more information. I think slowing down the process altogether is really important. Not everything is an emergency. And so when we have that space to sort of slow things down, it sort of, allows everyone to sort of cool their temperatures and allows perpetrators to clear their thoughts and to improve their decision-making skills. Don't reach for the gun immediately if it's not warranted. I mean, that certainly heightens fear, it heightens adrenaline, it heightens distrust, and probably increases aggression. And so that's one of the things I tell officers: if you don't have to reach for your gun, if you're not, at imminent risk in terms of safety, again, have that conversation. And also just, trying to maintain a certain level of respect. I think that, we are living in a culture where the way we develop, our ideas and thoughts about interactions with the police are oftentimes based on what we see portrayed in the media, sadly. Everything is recorded. And so de-escalation really helps to keep officers policy compliant. It reduces the risk of excessive force, and it enhances trust and improves community relations. So those are just some of the techniques.
Thank you for that. Chief Johnson.
I threw my hand up because you said that's what we should be doing. And I really just wanted to applaud Dr. Watkins for what she's doing with really developing psychologists or future clinicians. And I just wanted to share, I also think that's something we need to be doing better as a profession, and looking at the background, the education that the officers who are coming into this profession have. And we had the luxury of having an officer, the officer that's at the PERT program, he actually has a degree in psychology, which why I say that is most often people coming into the profession, they try to line up their education with what they think we want. And so oftentimes it'll be a criminal justice degree, but not only did he have a degree in psychology, he had actually worked and done research about disorders, abuse of substances and those kind of things, and worked in shelters. So he had an amazing foundation to kind of parlay into this psychiatric emergency response team. So I think it's definitely work that needs to continue. It definitely needs to be brought into our culture as far as what we're looking for and how we're going to serve our community. So thank you. And the last thing I'll say, in complimenting and giving kudos to Ms. Parlett, is that she is overseeing the crisis intervention training for the county and Palo Alto, as well as many other agencies. That's also another layer of training that almost all our officers go to. We require it, crisis intervention training. Again, it gives them another set of skills to interact with people. So with that, I will take my hand off. So thank you.
Thank you for those comments. Dr. Kirschman.
So I have a long ago memory just to show how much things have changed over the years. I did work in Palo Alto for 25 years, Chief Johnson, long before you got there. And there was a time when the field training program would use mentally ill, usually addicted people on the street as a training ground for new officers. Let's go down there and provoke this guy and see how our new trainees can react. So obviously that was highly inappropriate at the time, and I like to think that it's not happening any longer. In terms of finding clinicians to work with this mentally ill population, they also have to be able to work with the cops they're riding with. So while we need culturally competent clinicians who are treating law enforcement officers, we've got to find the kind of people who can sit in a patrol car, lose their attitude, if they have one, about policing, understand the culture and the pressures that are within that culture, be able to see things that they won't see in their office, be able to be around potential violence, have a sense of humor, because that's critical in working with law enforcement, to be able to be a direct communicator as opposed to the way many of us were trained to be non-directive. There are all kinds of, they have to be able to work shifts, get out of their office and be comfortable being out of their office, and be comfortable with an entirely different approach to both the officers and to the people they're going to meet on the street. Again, that was one of the reasons that the three of us wrote the Counseling Cops book, is because we felt that a number of clinicians who were seeing police every now and then were simply didn't understand the culture and made all sorts of mistakes as a result of that lack of understanding. And then the other thing I just want to add is that there's been some research years ago by a guy named Tom Tyler in New York City, and he was studying compliance with arrests. And what he found, I have never forgotten, that officers who had the most compliance with their arrests, in other words, they didn't have to fight with the person they were arresting, were those who felt themselves to be well treated and respected by their agencies.
Thank you for that. That is an important perspective and a nice piece of research to be highlighting. I think it really speaks to the culture within a particular department as well. Mm-hmm. And I'm intrigued by this idea of, sort of cop culture and really being able to work with officers and to overcome maybe some of the perspectives that officers bring to mental health. And Ms. Hendricks, would you please tell us a little bit more about your background and your perspectives on the issues we're discussing today?
Hi, it's good to be here. Yes, thank you. I am married to a former law enforcement officer. Years ago, we experienced our own combined critical incident when undiagnosed, because we had no idea what that meant to be diagnosed with PTSD or depression, or what he might have been experiencing. My spouse attempted suicide, and that was a long journey for us to get through together. There were a lot of resources that were not available to us and to me as a spouse. We found out about the First Responder Support Network, and my spouse went through as a client, and then ultimately I went through as a client. I returned as a peer and found my passion, which was not what I was doing at the time. and decided this is really something that's missing in this field. We don't have a lot of resources for spouses. And then as a woman of color, there's the intersectionality of police officers of color. I appreciate what Dr. Kirschman brought up, and it makes me think of how within that culture, there are other components that are very important. In particular, when I think about officers of color. And, when we speak about culturally competent, and as clinicians, I think it's important that we gain the training necessary to effectively work with the first responder population. And it is equally important to educate ourselves so that we can understand the uniqueness of the intersectionality of first responders of color and have awareness. This is really important, in my opinion, and have awareness of our blind spots and the nuances that are critical to understanding the complexity faced by the clients of color we serve, specifically speaking of officers of color. To me, what I think about is that this complexity is brought about not only by the dimensions of their identities in their personal and professional lives, but with society at large and the existing biases within the overarching systems, including the agencies they work for. Those nuances can be subtle and unspoken, but powerful in their effect. So for me, when we think about mental health for police and this population, it's important to consider all of these factors. And on the flip side of that, as a spouse, right, how does this impact their mental health? When we think of it as a totality, what are we doing to make the unit, and that includes the spouse, the partners, the family, what are we doing to help the unit become healthy? And that is a population that, as Dr. Kamina mentioned earlier, is often very forgotten. There is a lack of resources and understanding what that feels like to be the spouse of. I think Dr. Kirschman mentioned it earlier, something about how that can be a very difficult job in itself. And there's a lack of understanding of what that looks like. So as a clinician in the room, speaking with officers or first responders in particular, there is some lack of understanding of the impact that when they are a first responder, what that looks like when they get home. And that often officers will say to me in sessions, I have a hard time transitioning from me being the person that's in charge of the entire scene and then getting home and having to wear a different hat. And I have a hard time speaking to my spouse. I have a hard time speaking to my children in a way that I'm not speaking to a suspect. And so then, of course, that starts to create a different relational dynamic in the family household. So when we think of cultural competence, there are so many pieces of this that are really important to think about. And in terms of training clinicians, I agree with everything that has been said. And then training them to understand simple things like validating and understanding what it's like to be the spouse of, and how that ultimately will help the mental health of the officer if their household is healthy as well.
Thank you for that. Yeah, we're hearing about sort of a lack of clinicians, a lack of services, need for more with respect to working with officers specifically, but also with respect to working with individuals in the community and sort of our community and our correctional systems. Ms. Parlett, you come from a really interesting where you're actually trying to put these services in place. And so tell us a bit about the challenges that you experience there.
There are many challenges in having someone receive mental health services. First, they have to believe that they have the need for those services or agree to get those services. And perhaps family and friends help them understand that. And after someone decides to get services, they have to find and wait to receive those services. It's very difficult for a layperson to even know their loved one needs mental health services. I have talked to families whose loved ones were hospitalized and the family had no idea that there were any mental health concerns until they had to phone 911. They knew their loved one had said that there were, devices spying on them, but they didn't realize that was a problem. They kind of wrote it off and didn't want to see it, and just explained it away as the way they are. There's, I think, a lot more mental health awareness now, but not necessarily enough. And then the next challenge is the person needing services, accepting that they need services. This sounds so simple, but I'm not sure if you've heard this term, but there's anosognosia, which means that it basically means that they are unable to and unaware of their own mental health condition. So it tells you a lot that there's a word for this. That this is such a condition that it happens so often. We have a word for it. It prevents people from seeking treatment. So after that, after someone understands or perhaps does not understand, but agrees to get mental health help, they do not necessarily get it immediately. So if you have private insurance, you have to go to your primary care doctor and get a referral. And after that, you have to go work with your insurance company to get referred to a therapist. And then even then, maybe you also need a psychiatric provider. So then you'll have to go through another hoop. And that could be a couple months without getting any services. In the county, we do have mental health services, which we can talk more about when we're talking about solutions later. But it's just important to know that all these factors lead to someone perhaps having their first mental health contact with a 911 call.
Thank you for that. Ms. Hendricks.
Yes, I just wanted to sort of piggyback on what Ms. Parley mentioned is, in speaking about my own lived experience with my officer, who my husband was an officer at the time, having to call 911 on your own spouse who happens to be an officer is incredibly difficult. I can't describe what that's like. And at the time that he was an officer, very little was talked about in terms of mental health within the agency that he worked for. So then there was this sort of hush, like this didn't happen. You just take a day or two off and then you can go back to work. And so when that incident then occurred, that this is not, I can't just pretend we can't ignore this now. And my husband was hospitalized. Then there was this whole dynamic of, so what do we do? And no one could direct us. Right? And as what Ms. Parlett said, then we had to wait for, well, who do we see? Where do we go? And what happens now? And of course, then, him really understanding, do I need help? Because the first thing he worried about was what happens to my job now? Does this mean I'm not competent? And not wanting to tell the truth. And then the burden of me being told, you're going to have to figure this out and you're going to have to talk about this. And as a spouse, understanding that at that time I couldn't see past my nose. So it was like, what does this mean? And so I think what she mentions is really important to note, that then there are services that there's a delay, and there is this understanding that the individual doesn't have, that they actually need more help than just a 72-hour hold, and what that looks like. So I just wanted to piggyback on the importance of that.
Thank you for that. Yes, we're hearing a lot about a lack of culturally competent clinicians who can actually do this work with officers. We're hearing about a lack of community resources. We won't even get started on a lack of correctional mental health resources. We know that our correctional institutions are the largest sort of mental health providers in this country. There's difficulty in accessing mental health services. There's a lack of some resources for officers, especially in certain departments or in certain jurisdictions. So there are a lot of sort of problems that we have when we're talking about policing and mental health. I wonder about some of the solutions, and if we can discuss some of the solutions. Dr. Kamina, I know you have your hand up. I'm not sure if you're wanting to talk about solutions, but I will give you the floor.
Thank you. I certainly do want to talk about some of the solutions. One of the questions that came up was, what can we do to prevent officers from killing themselves? First responders are twice as likely to kill themselves as to be killed in the line of duty. This is a horrible statistic. I mean, even one death is one too many, but we need to do a better job. And I think one of the best solutions is the development of peer support. That's a crucial element. Now, some departments, it depends upon how the peer support team is selected, because, if they're in the good old boy system, a lot of officers feel that they can't trust them. And so therefore the peer support team really does nothing. But if they are guided properly, if they're trained properly, they can provide a tremendous amount of assistance and let people know that there is help out there. And should their problems become so difficult they can't manage them, they refer them to culturally competent clinicians. Some of the other problems that may arise, though, is one of the things that we've talked about is in this de-escalation and resourcing the police officers to do more police work and less social work, has been the idea of bringing in social workers or therapists in to be able to handle a lot of the calls that come into 911. And so, we have requires this coordination between dispatch, critical incident departments, the CIT training of police officers, mental health receiving facilities. And so we need a partnership with all of these different agencies so that communications can keep up with the ongoing changes in information so that when people arrive on the scene, they know what they're going into.
Thank you for that perspective. Chief Johnson, I wonder if you could talk a little bit about your perspective on some solutions or areas of opportunity for moving forward in this area.
Yeah, especially, I think I've spoken enough about, what we're doing in the community, but to the other panelists' comments, I really, really applaud you for helping us really with our well-being. And that's something that needs to be a priority from leadership across the state and across the country. In California, we did form a California Chiefs Police Officer Wellness Committee. I'm a member of that, but that was just formed in 2020. And that was really formed because of the rise in suicides in our profession. And for good reason, we needed to really try to reverse that trend. And the way to do that solution-wise is giving officers the opportunity to really have the conversations that it's okay not to be okay, because the reality in this profession, we're not, right? And there's a lot of stress, a lot of trauma that comes to us that we're exposed to, and we have to have a way to mitigate that. And peer support is great. It's awesome. Counseling, amazing. But there's also stigmas, as you've heard, with officers even having the willingness to reach out to their own peer support and then even maybe to a counselor. So there's programs that are being developed, I think because of our conversation. One of them is one that I co-developed with the Compassion Institute, who worked and developed a program out of Stanford University. It's called Courageous Heart, the Human Behind the Badge. And what it's designed to do is really develop the strength to be with suffering and really the courage to take compassionate action and really build resiliency to deal with that stress of all of life's challenges. And it really sets the officers' wellness and self-care in a context of the current realities of this job and introduces them with science, which is really important for them to understand why it's important to them. But I really think that programs like that, whether it's Courageous Hearts or others that are being developed, and they are being developed because of the urgency of this workforce resiliency in our country. But what I really believe is that as we offer these types of programs to our population of men and women serving our communities, it's going to help them not only regulate their own suffering and their own emotions and their own issues, but also better prepare them to serve our community for years to come. So I'm really excited that we finally have taken this serious, at least in our state, but there's so much more work that needs to be done. So with that, I will defer the floor.
Thank you. Dr. Hoy-Watkins, I wonder if you could talk a little bit about officer wellness and what's happening in your state.
Sure. So here in Illinois, something pretty tremendous occurred, I believe in the fall, which is enacted as of this year. Governor Pritzker signed a landmark criminal justice reform bill into law. And essentially what that law does, and I should give a shout out to our Lieutenant Governor because she also has police and public safety under her portfolio and takes a tremendous interest in the mental health and wellness of the police officers. So I don't want to minimize her role in that. But basically what this reform bill does is that it requires all officers, all police in the state of Illinois to have mandated annual wellness checks. And so It amends the Illinois Police Training Act from saying officers are required to have regular mental health screenings to they're required to have annual mental health wellness checks for both probationary and permanent police officers. So every organization, whether it's, a sworn campus police officer to, sworn Chicago police officers, everyone has to do an annual wellness check. And it specifies that, that those sessions will remain confidential. Just there has to be some communication that the officer engaged in those checks. And then also it requires that officers are not required to pay a fee for that so that they can be billed through their insurance or at no cost to the officer. And so I think this really sets the tone in terms of other states looking at what Illinois is doing in terms of requiring that wellness be put first. And this is also in response to the increased number of officer suicides in the state of Illinois. So again, it's a landmark, situation here, and police are looking to mental health now to work with their agencies to really help improve, some of their mental health initiatives, but also to make sure that those annual checks are done before the end of the year.
Thank you for that. Dr. Kirschman, I wonder if you could give us your perspective on some solutions after 40 years of working with police departments and officers.
I tend to be on the problem identification end of things in terms of solution. Well, we've heard some already today. The CAHOOTS program up in Oregon is a really good model for that. We unfortunately, when we talk about culture, we live in a country in which we still carry very medieval attitudes about mental illness. And so that's really difficult. Speaking to Dr. Hoy Watkins and Angelica Hendricks's issues, I am part, as are both of them, we are part of a group that are mentoring psychologists of color who have expressed some interest in coming into the field of police psychology. And I can hope all of us, if you want more information about that, you might reach out to one of the three or all three of us for more information about that. It's mostly for people with doctorates, but we do have some meetings every year. We meet once a month, right? No, once a quarter. We meet once a quarter, and include some people who are at the master's level as well. So that's another solution to some of the issues that involve the intersection of race and culture and policing.
Thank you. Ms. Hendricks, do you want to give us your perspective on some solutions?
Certainly, I agree with everything that's been shared. One of the other pieces is at the First Responder Support Network, they have a separate retreat for spouses and significant others. It is the only one in the country of its kind. So that speaks volumes for the need. And it is specifically for the unique challenges that spouses do face. And when I say spouses, I include partners, spouses, partners, any of that, significant others. But it is geared for the unique challenges that we face. I will speak from personal experience that when I went through as a client, and not trying to be funny here, but I thought, I'm coming here to learn how to fix him, the guy I'm married to and all the problems he's got. That's what I thought, right? And the reality is that it was not about that at all. It was more about understanding what was happening for me as an individual, because we all have things that we've experienced, and how that was then manifesting and showing up in the relationship and then heightening the dynamics between the two of us. And it also helped me understand what he was going through as an officer. I had no understanding of that. We had not had conversations about that. I don't think either of us knew how to do that. And so part of that was understanding, and that built compassion. Upon me returning home, I had a different level of empathy for what he experienced on the job, which was a piece that it's important to know. And so I think programs like the spouses, significant others and spouses at the First Responder Support Network are really important. It would be, the unfortunate part of that is that because it's the only one of its kind, at times when I worked on the staff, we had a list of 2 to 3 years of a waiting list long. And so that really speaks to, it would be great if other agencies, organizations, programs out there could be developed and or increasing funding for and grant funding for the spouses program so that we can have it in other states. We have it in California. So that's, I think, is speaking to one of the pieces of the solution in addition to what others have shared.
Thank you. And Ms. Parlett, can you give us your perspective on solution and maybe some resources as well?
Yeah, let me start with a huge source of hope. We have had 911 since about 1968. And this was huge because there was a single number for emergency services. We now have 988, which is the number for suicide throughout America, and it routes you to the nearest suicide center. This is amazing. This is saying that mental health warrants a serious condition requiring services, just like 911. This is destigmatizing the need for mental health treatment. I mean, it's very powerful and hopeful to me. If someone's in a situation which warrants phoning 911, it is important to know that you should ask for a CIT officer and alert the 911 operator that this is a mental health call. The first place to seek mental health services, if it's not urgent in our county, is our 1-800 number. It's 1-800-704-0900. And I can put that in the chat later. We have a suicide crisis hotline for talk or text. So that's huge, so that younger people can text with the suicide crisis line. And we also have a substance use line. We offer services to anyone, but many assume that services are only for those with insurance, and that's not the case. There are challenges. We help people without benefits apply for services like Medi-Cal. But if you do not qualify for Medi-Cal, we can still work with you. We do have ability to pay as well. The county is very good that way. For more urgent kinds of needs, we have mental health urgent care at Valley Medical Center on Bascom, open 8 a.m. to 7 p.m. every day, and that includes holidays. We also have mobile crisis services available 24 hours a day, 7 days a week.
Thank you for that. That's a wonderful list of resources. Very much appreciated. Thank you all for this discussion of some of the problems, some of the definite challenges, some solutions, some reasons for hope. I see that we have several questions and comments that have come in through the chat and through the Q&A. So I'll start with one that I will direct to Chief Johnson. It's from Bruce Bonger, who's a faculty member at Palo Alto University. And he says that for over 3 years in the late 70s and early 80s, he was a senior psychologist and duty officer for the Los Angeles County Department of Mental Health Psychiatric Emergency Team, so PET, Psychiatric Emergency Team. There was funding for dedicated PET teams to deploy with police and sheriff's officers in the field. If such funding was readily available from state and federal sources, do you believe that in 2022, local law enforcement would find that model useful and effective?
Oh, absolutely. And I mean, to be honest with you, that's how we were able to get this PERT program off the ground was, a collaboration with the county who funds the clinician and we fund the officer. And Anna Eshu's office, for example, that's another one where we're receiving for the city of Palo Alto some funding to develop some mental health response protocols even further than what we have. So absolutely funding, I think, would be phenomenal. And again, I do think this is when we start reimagining how we allocate our funds for policing, I think more and more agencies are going to see the value to allocating funds specifically for these emergency type response teams where mental health clinicians are in the car with the officers.
Thank you for that. A couple of comments to Dr. Hoy Watkins. Thank you for sharing specific techniques on how officers can de-escalate. A question in general that's been posed is it a requirement for our first responders to see a therapist?
I can answer as the chief, the answer is no. And that's probably the problem, right? I think it was Dr. Watkins who brought up what they're doing in Chicago. We have to see a psychologist when we're hired. That's part of the process to get evaluated. But you got to remember, when we're hiring people, most of the time they're healthy, they're well, they haven't been exposed to the stress and trauma. So I'm a huge advocate to where I think it would be very, very beneficial to have a process like that to where annually or semi-annually, whatever it is, that we go back. I mean, I've been at multiple agencies now, so I've had to go through the psychological evaluation 3 times in my career, but I think that's because of choice, because I chose to go to a different assignment. I think 3 times in a career is a small amount, but I think extremely, extremely valuable.
Thank you. Dr. Kirschman, I'll direct this one to you. It's a comment and a question, I guess. Trying to change department cultures will be tough. I work with a department that partners with county behavioral health, but non-licensed people are being stationed with the officers. These people are going into the field with officers, dealing with the situation, evaluating the citizen, then calling a licensed therapist who likely has no experience in the field and discussing the case while on scene. It's not ideal. In addition, the department is very split on the value of mental health training and services. And recently, the department has decided that we are not responding to 5150s. In addition, I've heard reports about how even after a mass shooting, the department did not encourage or provide mental health services for officers until months later. And when they did provide it, they had everyone in one room, including captains and other higher ranked people. So nobody could admit or raise their hands or say they needed help coping, or they'd be looked down upon and considered weak. Just wondering if you could comment and talk a little bit about the culture and in your experience.
Well, I responded to that person, you may have seen that, by saying bad, bad, bad. I have no idea how a department can refuse to respond to 5150 calls. I'm not even sure that is legal. It is very hard to change department culture, and it happens slowly. And it requires everybody at all levels of the organization to be a part of that. And sometimes you just have to get rid of the old dinosaurs and bring the new people in order to, because the older folks are not that amenable to change. In terms of the this debriefing that was done after a mass shooting, of any clinician who understood what they were doing we would never have put people of different rank together in the same debriefing, because that does nothing but chill anybody's ability to speak, because you're not going to, it's hard enough to confess, that's probably what it feels like, that you're having problems to your contemporaries, to your coworkers, but to do that to the people who evaluate you, supervise you, and may be instrumental in you getting promotion will just never happen. That was really, really dumb.
Thank you for those comments. I'm going to direct this question to Dr. Hoy-Watkins. How will the annual evaluations be standardized across the state or across officers? Are there specifics that will be covered during the evaluation, specific assessments? Do you have any idea what this looks like on a larger scale?
On a larger scale, I don't know that it's been standardized because it's new. What I do know is that it requires that the sessions be a minimum of 45 minutes to an hour. The statute specifies that it must remain confidential. I believe that, and Ellen, you may know, but I think there are some police psychologists who are actually working on preparing some guidelines so that there's a standard for us as psychologists who plan to engage in these. But here in the state of Illinois, I believe psychologists are probably doing different things. Testing is not likely to be a requirement. But I do think it's important, to assess, obviously for depression, anxiety, work-related stressors, home-related stressors, community stressors, but there is not a standard as of yet.
Thank you for that. Chief Johnson, are police unions involved in helping their colleagues?
Yeah, actually, I think that's really, again, going to the culture and really making it acceptable to have these alternative programs available or access to services available. And to everything that my colleagues have said here is very true. There's a stigma, and it's very challenging for officers of various ranks to be willing to go to a union president or even somebody that they don't trust. So you really have to create, and that takes time, create that environment of trust so people feel it's okay. They're not going to be judged extensively, as far as they're actually going to be given the resources they need to be well. And I think that that's the direction we're going, and that's the direction we need to go in this profession if we really want to sustain a healthy workforce. Because the last 2 years alone, and it's not just law enforcement, all the stressors that we've had to be confronted with have magnified the issues. and especially with remote work, officers' relationships at home, a lot of things, the homeschooling, it's just been a cascade of events. So we do definitely need to do more involving everybody, so we're all on the same page moving forward.
Thank you for that. This question that has come in mentions Ms. Hendricks, as mentioned by one of the presenters. That was you, Ms. Hendricks. Her police officer spouse had experienced suicidal behavior. Law enforcement personnel have a high suicide rate. What should be done to address and reduce suicidal behaviors by law enforcement?
I think from this perspective, as the spouse, I would say, one of the things that I hear now in working with officers in the therapeutic room is that they have all these initial orientations and onboarding at the job, and they talk about all the benefits and the wonderful things, and they don't actually talk about these are the things that will likely happen, and this is what may actually then happen in your household, and these are the resources that you have that you can call before you get to that point. And so I think that's really an important piece, is for spouses to understand this is what it looks like. This is what it could look like. If you start to notice these behaviors, maybe reach out to somebody and inquire. And I speak from personal experience. Much of this I didn't see. I didn't know. I was not a therapist at the time. And so I didn't understand that these were things that I see now and I address as huge red flags. I wouldn't have known that at all. And so I think part of that starts with even how do we talk to officers when they're going through the academy, maybe incorporating training that has to do with what part of this affects your household, and have some component of that include the spouses in presentations or information that they're given, right? So that's one solution.
Thank you. Dr. Kirschman.
Well, I agree with Angelica, that kind of normalizing and forewarning both officers and families has to be done in the beginning of the career. However, this is like doing premarital counseling with people who are deeply in love. You've got to do it again, because at that point, early in the career, the officer and the family have no Velcro for that information. They don't have any road wear. They don't have any experience. They think this isn't going to happen to me or to us. So I think it's great to plant the seeds early on, but then you've got to reinforce it. I would say every 5 years, somehow get that message out again.
Thank you. Dr. Kamina, I think you were responding maybe to this question when you were speaking, but I'm going to ask it again and give you an opportunity to put information out there for others who are listening. Jim Beale asks, developmental disabilities are different from mental illness conditions. Could you address training in this area? And then there's also, can Police Officer Standards Commission, California, increase the required training for the minimum hours in the mental health area?
There is an organization called POST, Police Officers Standards and Training, and many states throughout the country followed the California model of POST. And basically it codifies all of the different courses that have been approved by them for training. And officers are required to take so many hours per year in training. And so all of these various courses are offered. And some are required and some are not, but they're all really valuable. Working through the POST system, though, is where one would go in order to be able to get these mandates. And it's rather difficult because it's a huge panel that decides on what should be mandated and what shouldn't. And it is important. And I think that more needs to be said about differentiating people with developmental disabilities versus those with mental illness. And I think that training would be essential. One of the things that I've noticed is that departments may try to follow this critical incident training model, and they will use different forms in order to be able to help officers get trained, but only 20% is considered this model standard. My belief is that everybody should be trained in this because, 20% of the people are not out on the street. There are all sorts of officers are out on the street, and everybody should know about about this de-escalation and when to call for a CIT officer. And I think that would be extremely helpful. I wanted to just mention one other thing in the question that was addressed to Alan earlier, talking about doing debriefings and talking about treatment that has been done in a department. It sounds to me like the people that were being sent, the mental health people who were being sent, were not trained and didn't know how to deal with the population. And they need to get trained before they are assigned. And if they're not, they're no use and they can do more harm than good. So please emphasize for your departments that these folks need to be trained.
Thank you. Appreciate that. We have just a couple minutes left, so I think maybe 2 questions. This first one is for Dr. Hoy-Watkins. In the event that the clinician or therapist determines that the officer in question requires additional meetings, how is that addressed? Since they fulfilled the mandatory 1 annual meeting, are they obligated to continue with treatment or no? Can you speak to them?
Yes, it's my understanding that if there is a concern in terms of the need for follow-up treatment, that recommendation, well, let me say at the outskirt of the conversation, obviously you would discuss limits of confidentiality. And if there were a concern regarding imminent risk to self or others, obviously that would be information that would need to be disclosed. And if there was a need for any additional treatment, that recommendation would be made to the officer.
Thank you very much. Is there a public, and I'm going to open this up because is there a public health / mental health education outreach aspect to let the general public know about these progressive programs and help restore more faith and trust in the police force? I don't know of any real concerted effort on this. Are there panelists who are aware of public health or mental health education outreach to let general public know about these programs and resources for officers?
Well, they can read my mysteries because I try to talk about that, but it won't be a list, of course, but it will be, I'm hoping, and some of my readers say, gee, I didn't know that about police work. So, it's sort of guerrilla undercover educating of the public in mysteries.
Thank you for that. I think with that, it is 1:15, so I will extend a huge thank you to all of our panelists for engaging in this discussion and making your perspectives known, and for the great work that you've been doing both on the policing and the mental health side. So very much appreciate the time today that you took to engage in discussion about these issues. And a thank you to everyone in attendance for joining us for this discussion. And again, to the panelists, thank you very much for your expertise and your time today.
Thank you.
Thank you very much.
Thank you.
Thank you.